Hello, my name is Dr. J. Michael Bennett, and this is the next video on demystifying the orthopedic exam. We're just going to go over some nuts and bolts and basically just kind of gloss over what we do as orthopedic surgeons and what we're looking for when we evaluate a patient. Many of you go to the doctor's office and we run through all these tests and we go through them pretty quickly and you don't really know what we're looking for, and I'll kind of try to explain that today. Today we're going to go over a knee exam, and first and foremost, it's important to really peruse through the physical exam, or excuse me, the history of the knee injury and the mechanism of injury, because that can really kind of tailor what kind of exam that we do. But after we get a good history from the patient, the first thing we do is we look at the patient's knee and look at the patient, how they're walking. If they're walking into your office on crutches, or if they're limping, then that obviously gives us an idea of how much pain they're in or what kind of injury they had regarding their knee. The next thing we do is we look at the knee. We have them pull their sleeve up or their pant leg up and look at the knee. If it's swollen, if it's bruised, if let's just say they can't bend the knee or extend the knee, that indicates definitely a fracture or some sort of deeper injury that may need some further testing. So first and foremost, we'll look at the knee, see if there's any swelling or abnormality in the knee. We'll see if they can actually extend the knee, and if they can lift the leg up on their own, then that usually tells us a lot. That tells us that, number one, their kneecap is working, their quad tendon's intact, their patella tendon's intact. Some patients that can't lift their legs straight up, that just tells us that there's a deficit between the quadriceps and the patella tendon here and the patella. That whole mechanism is not working, so it could be a patella fracture, it could be quad tendon rupture, it could be a patella tendon rupture. So the next thing we do is we have them bend their knee, okay, and look at their motion. I always compare it to the other knee, okay, because if one knee bends all the way down here and the other knee doesn't, or bends further, then there's something wrong with this knee. Maybe it's stiffness, maybe it's arthritis, maybe something physically is getting caught in the knee, keeping them from fully bending the knee, especially if it's painful. So you compare it to both knees, looking at their range of motion in full flexion and full extension. The next thing we'll do is have them bend the knee, and we'll do basically what's called an anterior posterior drawer test. We have the knee at about 90 degrees here, and we just pull and push the knee and see if there's any kind of translation from the tibia to the femur, and that gives us an idea what the cruciate ligaments are doing, the anterior cruciate ligament or the posterior cruciate ligament. The next thing I like to do is palpate the joint on the inside aspect, the joint line, or the outside aspect of the joint line. If the patient comes in and they have specific pain on one side or the other side, that usually indicates a cartilage injury or maybe a contusion, specifically on the medial or lateral side of the joint. But this kind of helps us make sure that they don't have any kind of meniscus pathology or cartilage lesions. The next thing we do is have them bring the knee back to full extension, and then I flex them at about 30 degrees or so, 30 to 40 degrees, and then I do a light translation of the knee to see if their ACL is intact. It's called a Lachman's exam. So it's either a Lachman's positive or negative exam. There are different grades of Lachman's. You can have an ACL sprain, which may give you a little bit more looseness or laxity on one side compared to the other. But we use this test to see the integrity of the ACL ligament. Next, I like to look and see if the patient has an effusion or any swelling in the joint. We'll kind of squeeze the upper area of the joint and kind of palpate down and see if there's any sponginess or swelling in the joint itself. That'll indicate some sort of inflammatory process in the knee. Then I evaluate the kneecap, and I'll actually push on the kneecap, see if the kneecap slides laterally on the outside or slides medially. If the patient does not like you doing this, or they jump up, or they want you to stop, that is a patellar apprehension test, and that means that kneecap's unstable. And that may mean that the ligament on the inside that actually helps stabilize that kneecap is stretched or torn, and you don't want to push that too far over. You don't want to stress it too much because you could very well create a patellar dislocation. So you just very lightly translate the kneecap forward and sideways. If you have pain on the outside aspect of the kneecap, they may mean you may have a little cartilage wear on the outside of the kneecap. Sometimes there may be a tracking injury like patellofemoral syndrome in the kneecap, where the kneecap's just a little tilted because of the weakness in the quadriceps. So this tells us a lot. Next, we'll just bend the knee again. We'll palpate the patella tendon or the quad tendon just to make sure there's no patella tendonitis or quad tendonitis. We'll evaluate the ligaments on the inside and the outside of the knee. So we'll basically have the knee, drop it over the side of the table, flex it about 30 to 40 degrees and stress it outside and stress it inside. This tests the medial collateral ligament and the lateral collateral ligament. Then we bring it to full extension and stress it again, inside and outside. That'll tell us if the collateral ligaments are intact or if there's any sprain or injury to the collateral ligaments. The next thing we do is something called the McMurray's or Steinman's test. We'll actually hyperflex the leg, and we grab the foot and we rotate that ankle and that knee, and we bring the leg to full extension. Then we rotate and swivel it the other way and bring it into full extension. That tells us if you have any kind of meniscus pathology. If you have pain when you rotate the knee, or the patient comes in and says, oh yeah, when I twist or turn I have significant pain in the knee joint, that'll indicate a meniscus tear, so an MRI is often warranted in that case. Just like I mentioned before, if we look for swelling in the front of the knee, you can have swelling in the back of the knee. Some patients will come in and they say they have a lot of fullness in the back of the knee or swelling in the back of the knee. Many times that could be a mass in the back of the knee. It could be a Baker's cyst, which is a benign fluid-filled cyst in the back of the knee that usually occurs when we have any kind of swelling in the joint or effusion in the joint. The cyst occurs because the fluid goes to the pathway of least resistance, and sometimes it's posteriorly in the back of the knee. But either way, it's a good idea if you're having any significant knee injuries or knee issues to get an evaluation by an orthopedic sports medicine physician. So hopefully that kind of helps demystify a little bit of the orthopedic exam regarding the knee. If you have any questions or comments, please go to our website at www.jmichaelbennett.com or call us at 281-633-8600. Thank you.